Hello, this is Jeff Swenson. We'd like to take a moment to show you an instructional video on the use of a new fenestrated needle for fascial plane approach to peripheral nerves. This needle is manufactured by IMD, whose website is seen at the top of this screen, www.imd.inc.com. The sciatic nerve is the nerve that we want to illustrate with this particular segment. We've noticed that major nerves in the lower extremity are positioned in well-defined fascial planes. And using that knowledge, we can use a needle to deliver local anesthetic into those tissue planes and get local anesthetic to the nerve without having the needle in immediate proximity, especially the needle tip in immediate proximity to the nerve. The design of the needle is a pencil point, which allows the operator to have visual and tactile feedback of tissue planes as the needle is advanced into tissue. It is relatively atraumatic to vessels and nerves compared to conventionally beveled needles. The side fenestrations provide improved distribution of local anesthetic to fascial planes, and the fact that the needle has an occluded pencil tip prevents intraneural or intravascular outflow from the needle tip. There are three design options. There is a 1 centimeter fenestrated segment, a 2 centimeter fenestrated segment, which we'll be using in this video, and a 3 centimeter fenestrated segment. There are three examples of blocks that can be facilitated by this needle: the femoral block, the sciatic block at the popliteal fossa, and the proximal saphenous or adductor canal block. Today we're going to focus on the sciatic nerve at the popliteal fossa. The injection with the fenestrated needle can either be performed medial to the sciatic or between the tibial and peroneal nerves at the point where the sciatic nerve bifurcates. This is an artist's rendition of the popliteal space. You'll notice that the sciatic nerve can be blocked in most cases, traditionally, by advancing the needle directly over the nerve. In many cases, contacting the nerve and causing a paresthesia, and in some cases, causing injury. By contrast, the fenestrated needle allows us to advance the needle a good bit medial to the nerve and have local anesthetic leave the needle in tissue planes that lie in a coronal plane relative to the nerve, but this distribution of local anesthetic surrounds the local anesthetic around the sciatic nerve, resulting in a successful block without having the needle tip in close proximity to the nerve. This is at the level in the popliteal fossa where the sciatic nerve has bifurcated into the tibial and peroneal nerves. Once again, a conventional way to block this would be to bring the needle right down on top of the nerve and either seeking or getting a paresthesia and potentially causing some minor or severe nerve injury to the tibial nerve. Again, the same thing for the peroneal nerve. Traditional methods suggest that we approach the needle in immediate proximity to the nerve, which again may result in a painful paresthesia at best. By contrast, with the fenestrated needle, we can advance the needle between the two nerves and maintain a safe distance between the tip and both of the nerves, yet deliver local anesthetic in the tissue planes which lie in a coronal fashion between the two nerves. This is just a still image showing how dramatic the tissue planes of the popliteal fossa are arranged in a coronal plane. So here we have the sciatic nerve with the arrows illustrating many connective tissue layers oriented in a coronal plane. In this image, we are going to show an injection medial to the nerve. So here's biceps femoris muscle. Here is semimembranosus, semitendinosus. Here's popliteal artery, popliteal vein. Here's the sciatic nerve. We could either inject on top of the nerve or come in a safe distance medial to the nerve and deliver local anesthetic in these coronal planes to fill up the space or the tissue compartment that the sciatic nerve is in. This is a live image showing injection real time. Once again, we have the biceps femoris laterally, the semimembranosus, semitendinosus medially, the popliteal vessels, vein and artery, and now here we have the sciatic nerve. As we advance the needle a good bit medial to the sciatic nerve, our outflow of local anesthetic is going to be in the distal 2 centimeters of the nerve, or distal 2 centimeters of the needle tip. So we're going to have an outflow pattern as demonstrated by these white arrows. But you can see that the resulting distribution of local anesthetic is very effective. If we inject below the bifurcation of the sciatic nerve at the level of the tibial, once again, conventional methods instruct us to advance the needle directly over the nerve. Same with the peroneal nerve. By contrast, if we use the fenestrated needle, we can safely advance the needle between the two nerves without targeting either one and get distribution of local anesthetic through the fenestrated side ports evenly in this space to provide a successful block. So here's an example of the block below the bifurcation of the sciatic nerve at the level of the tibial and the peroneal nerves. Once again, we have biceps femoris on the left, semimembranosus, semitendinosus on the right, peroneal nerve on the left, tibial nerve on the right. You will see some tenting of the tissues as we advance the pencil point needle between the two nerves as we give our local anesthetic. Once again, very even distribution of local anesthetic in this plane. As we move the needle even more out of the way of the nerves, so now we can see when we image with ultrasound, we're going to move the transducer slightly just to assess the volume. And you will see a very, very, very good surrounding of both the peroneal and tibial nerves by local anesthetic resulting from this fenestrated needle injection. Thank you.